Hey guys, good evening. Hope I'm audible and visible. Good evening, Rohit. Good evening, Siddhi. Okay, a very good evening once again, guys. Hopefully, you must have gone through yesterday's RBC disorders. A quick review. We'll start with WBC disorders today without any delay. I hope that you will enjoy FARRE and make sure that university exams will be very much helpful, right? So first of all, to begin with, we are going to go through the same way what we did the RBC disorder. The first slide, what I'll be giving you is the keywords for all the diseases which you're going to discuss in the FARRE, right? Then we'll definitely discuss the disease one by one. In the same way, I want you to present an exam, be it the etiology, the pathogenesis, the microscopy, the mutation, the prognosis, everything, right? And then finally, I don't have clinical scenarios today, but I'm going to give you and test you the same keywords, and I want you to see how many of you can pick up the answer and give me the right answer, right? If you're good to go, let's start once again. We are going to go the WBC disorders. Fine, perfect. So this will be the list of diseases what we'll be discussing today. I'm going to discuss about CLL, the lymphomas, non-Hodgkin's, the Hodgkin's lymphomas, the leukemias, the myeloproliferative disorders, and also the plasma cell myelomas, right? This in gist will cover more than 80 to 90% of the questions which might be asked. There will definitely be bounces. Don't worry about that. Our goal is to make sure that we'll cover the maximum. Bounces come once in a while. That is completely fine, right? So let's go. For chronic lymphoid leukemia, and small lymphocytic lymphoma, right? See, if you have read before the Robbins, both of them are actually the same, one and the same diseases, right? But if I have to particularly mention small lymphocytic lymphoma, the history and the keywords will be an elderly person, generalized lymphadenopathy, and the peripheral smear being normal. That is very, very classical. If it's a pure small lymphocytic lymphoma, and the lymph node will have something called proliferation centers. But if I'm just going to say that CLL, right? CLL is the common word. So SLL is not that common here. CLL, again, is an elderly, painless generalized lymphadenopathy. You might have a clinical history of Evans syndrome, and the key microscopic finding will be smudge cells. I'm sure everyone must know how to identify a smudge cell, right? That's not a difficult thing at all, right? So these are the keywords here. Syed, I tried. I don't know why it is happening. I'll try to ask the studio guys to fix it next time. Fine. Okay. Feedback check. Perfect. So mantle cell lymphoma, I've told you multiple times a tiny way to remember the translocations. Mantle, we keep it double L to know that translocation 11 and 14th chromosome, right? Mantle cell lymphoma can be nodal as well as extranodal. So if it's nodal mantle cell lymphoma, I don't have a difference in the history of any other non-Hodgkin's lymphoma, right? So if it is something which is not nodal, GI symptoms can be there, right? And this is very, very, very classical. For an undergraduate, if you have to give a clinical history, which is suggesting a mantle cell lymphoma, if the intestine presents polyps, multiple polyps in the intestine, that's classical for mantle cell lymphoma. Do remember them, and you know the mutation or the marker, cyclin. It's cyclin, ignore the spelling, fine? Okay. Then follicular. Follicular lymphoma, classical history, be it in a real life or in an exam, it's only one thing. It's a very, very, very slow growing tumor. If you have a lymphadenopathy for like 7 years, 8 years, right? Years of lymphadenopathy. It's a very, very slow growing tumor. That's very classical for follicular lymphoma. Other than that, you might not have any more classical feature. Microscopy, allow multiple follicles, and by default, you might end up in having a BCL2 positivity as well. That's also a very classical clinical clue for follicular lymphoma. Marginal zone lymphoma or maltomas, right? Before going to marginal zone lymphomas, I'm just moving it away. I want you guys to comment which all organs in the body you can have marginal zone lymphoma or maltomas. I'll start with the common location, GIT, stomach. Can you guys add any more places where you can see marginal zone lymphoma or a maltoma? What comes to your mind? Might be right, might be wrong, doesn't matter at all. Since we have completed the entire pathology, you should be able to answer that, right? Good evening, Arya. You can have maltomas in the thyroid, secondary to long-standing autoimmune Hashimoto's thyroiditis. You can have marginal lymphoma maltoma in the GIT stomach, secondary to chronic H. pylori or your autoimmune gastritis. You can have maltoma in the salivary gland. You can have maltoma in the lacrimal gland, secondary to Sjogren's syndrome, right? So anywhere where I have a chronic, long-standing, recurrent stimulation of lymphocytes, all of them can result in maltoma. So the history of maltoma is based on the previous history, right? That's how it is. You can have dyspepsia if it's in stomach. You can have ulcerative H. pylori. Since the most common location is gastric maltoma, mostly the symptoms will be suggestive of that. But like you guys said, I can have in salivary gland, I can have in thyroid, I can have in pancreas, any place where there's a chronic lymphocytic stimulation. Do remember them, right? Buckets. I always keep saying that if there's a lymphoma in a child, that is the most characteristic. Not even starry sky. Even before looking at starry sky, by the age, I'll be able to take care of it, right? Age, you have jaw swelling, African kid, or an abdomen mass, or an interception, I wanted to think of Burkitt's lymphoma. Starry sky, everything comes in the microscopy only, right? Clinical clue, these are very, very classical. Child with NHL is Burkitt's. I'll ask you one more question. I want everyone online here to comment. Doesn't matter if you're wrong. Child, if it's a leukemia, what leukemia you'll think of? Child and a lymphoma, we obviously think of a Burkitt's lymphoma. If it's a child and a leukemia, what leukemia you'll think of? There are only two leukemias for us, right? What leukemia you'll think of? Exactly, Sinash. You'll think of ALL, acute lymphoid leukemia. That's enough for me for diagnosis. Child leukemia, the first thought should be an acute lymphoid leukemia. Fine? Perfect. The next thing is Hodgkin's lymphoma. See, Hodgkin's lymphoma does not have a characteristic feature. I don't have like this is what I'm going to see in the clinical history. It's generally lymphadenopathy, that's all, right? Hodgkin's does not have a classical feature at all. It's the microscopy which helps us to identify this Hodgkin's or non-Hodgkin's. Burkitt can have a feature. CLL can have a feature, right? But Hodgkin's very, very unlikely. You'll have the B symptoms plus or minus, and this could be there. This could be there. Please remember it. This could be an important finding for you for Hodgkin's, and also one of the classical types of recurring fever called as an Pell-Epstein type of fever. These are only two features which are a bit unique to Hodgkin's. Itching post-alcohol, pain post-alcohol is classical for Hodgkin's lymphoma, and also you have your Pell-Epstein type of fever, classical for Hodgkin's lymphoma. Do remember, these are only two clinical clues. Rest everything is microscopic and IHC based diagnosis, right? And like you guys exactly said, child with a leukemia, I'm going to go with ALL. ALL has two types, B and T. If it's TALL, there'll be a history of mediastinal mass or an X-ray picture being shown where the mediastinum is being widened. It's thymus dependent, that's why you have TALL in the mediastinum, right? BALL will have predominantly lymphadenopathy and easy bruisings and other things, right? Child leukemia, I'm going to think of ALL. AML is very, very, very wide. It's very diverse. One AML, which I want you to remember, we have read them also in the exam paper discussion. AML M3, very, very classical. Young age, middle age person, bleeding gums, signs of DIC, classical for AML M3. That's diagnostic of AML M3. Microscopy is also unique. Treatment is also unique. We'll look at them very, very soon, right? CML. I don't want you to tell the triad of CML, right? Elderly person, massive splenomegaly, which will cross the midline sometimes, right? And microscope, you have leukocytosis with left shift, diagnostic of CML, right? It's massive splenomegaly, plus you should have leukocytosis. I'll give you one more important history. Let's see if any one of you is able to give a right diagnosis. Patient who's an elderly person, same patient as an massive splenomegaly, okay, massively enlarged spleen, okay, but in the CBC, the patient has pancytopenia. Can anyone tell me what's a diagnosis or differential diagnosis for this? Elderly person, massively enlarged spleen, the patient has pancytopenia, not leukocytosis like CML. CML should have leukocytosis. There's no variant of CML which will have cytopenias. What will be the right diagnosis here? Anyone? Great. One of the right diagnoses for me here is hairy cell leukemia. Hairy cell leukemia also will have a very, very classical finding. There is one more diagnosis for this, which could be myelofibrosis. Myelofibrosis also will have massive splenomegaly. Myelofibrosis also will have pancytopenia. Do remember them, right? So these are variations. Variations are very, very important so that you get the right answer. That's it, right? But again, hairy cell leukemia or myelofibrosis being asked for a second year is very unlikely. So frankly, it may not come, but in NEET PG exam, INICT exam, you should definitely know the differentials. Fine. Last but not least, multiple myeloma. Though you have multiple things in multiple myeloma, elderly, bone pain, fatigue. This is classical. Low backache is classical, right? Low backache in elderly, and this fatigue. Microscopy shows anemia, hypercalcemia, the CRAB features, diagnostic of multiple myeloma, right? So you have CRAB features, diagnostic of multiple myeloma, right? Perfect. So these are the diseases which we'll be talking about today, right? So we'll cover almost the entire thing with respect to WBC disorder. We'll go slow, we'll go one by one. Again, I want a very active participation so that it will be a very good revision for you guys, right? We have taken lots of classes. Let's start revising. Let's have a conversation. The conversation, once bilateral, will be amazing for you to remember for a longer time, right? The first thing is about CLL, chronic lymphoid leukemia, or a small lymphoid lymphoma. I've given you a template in the classes, in the regular classes, right? The history batch. We need to know about the origin. We need to know about the etiopathogenesis, then the microscopy, CBC, lymph node, and the markers, and complications and prognosis if you know anything about them, right? Same template is what we're going to follow here as well. CLL bar SLL, which means it has dual origins. The common origin is naive B cells. CLL is going to be originating from naive B cell, and actually SLL is originated from post-germinal center B cell, right? That's the origin for SLL. But generally, if a question is asked on CLL, SLL, I want you to focus on CLL only, because SLL is not that common. You will not have that, but CLL is very, very predominant. I want you guys to know about it, right? So when you look at the etiopathogenesis, you have lots of known mutations in CLL, right? You might have translocations involving chromosome 14. That's a common thing, right? This is true for every non-Hodgkin's lymphoma. Chromosome 14 translocation, something is very, very, very common, right? The immunoglobulin heavy chain, if you remember B cell journey, we know why it's happening. Because of the translocation involving chromosome 14, what's going to happen is, I'm going to have an overactivation of enzyme called Bruton's tyrosine kinase. I want you guys to mention this because this is not something which has been there for years. It's a new addition, so I want you to definitely remember that, right? Ultimately, what happens? Bruton's tyrosine kinase becomes overactivated. That will go and proliferate the naive B cell. It will not proliferate any other component. It will proliferate the naive B cell. The term naive is also important because the origin is of the naive B cell, right? B cells proliferate, that's all, right? Why Bruton's tyrosine kinase is such important thing is, I can block them for treatment. Can anyone comment what is a drug which is used to treat CML, which also blocks tyrosine kinase? We can block Bruton's tyrosine kinase, BTK is Bruton's tyrosine kinase, by a drug which is ibrutinib. You are absolutely right, Siddhi. 13q deletion and 12q disomy are much more specific. I am just telling you, if you are finding it difficult to remember, there is a template which you can add on to it. That's all, right? CML is imatinib. Here we use a drug called an ibrutinib. Ibrutinib will exactly stop Bruton's tyrosine kinase, right? So once you have lots of naive B cell, all these naive B cell is going to be in the blood circulation. That's why we call it a leukemia. Origin of the tumor coming from the blood cell, and circulation, I'm going to have lots of WBCs. We call it a leukemia, as simple as that, right? Symptoms, two findings which is very, very important for CLL, right? It affects the adults, painless lymphadenopathy. See, this is common for any lymphoma. So you can write like a template. Painless lymphadenopathy, generalized lymphadenopathy, more than 2 non-contiguous lymph node sites. You can write pages on it. But what is more important for me is, CLL is a place where it can break the autoimmune barrier. CLL can have autoimmune hemolytic anemia. We read in the last class, both cold as well as warm autoimmune hemolytic anemia. At the same time, CLL can also increase the risk of autoimmune thrombocytopenia, that is ITP, right? CLL can have autoimmune hemolytic anemia and ITP. Together with this, we have a syndrome called as Evans syndrome. Evans syndrome is nothing but CLL plus autoimmune hemolytic anemia plus ITP. That combination is called an Evans syndrome, but this is something which is unique for CLL, right? This can be seen in almost every lymphoma, every non-Hodgkin's lymphoma. Elderly, you'll have classical generalized lymphadenopathy, but this is very, very unique for CLL, right? Okay, so what do I see in peripheral smear? I have leukemia. By default in peripheral smear, the first finding should be leukocytosis, right? There will be increased number of mature lymphocytes. You will have leukocytosis. If I have to go with specific criteria, if the absolute lymphocyte count, okay, the absolute lymphocyte count of more than or equal to 5,000 per cubic mm per ml, right? This is the classical diagnostic criteria for CLL. To call it a branded CLL, I need absolute lymphocyte count more than this, and all these lymphocytes should be monoclonal, which means it should have the same marker in flow cytometry, right? So, and microscopy will have smut cells. Again, someone asked me yesterday how to draw a diagram. This is enough for me. Put 5, 10 round lymphocytes and one destroyed. That is smut cell. Should it be beautiful artistically? Doesn't matter at all. This tells, yes, I have more mature lymphocytes and there's a destroyed WBC, which is smut cell. If you want to draw a diagram, draw it. Otherwise, this word is enough for me, more than enough, right? So here, this is the reasoning why question. Why do we have smut cells in CLL? If they ask a question, it's simple. It's a disease of naive B cell, which means they are in my blood circulation. All the WBCs in the blood circulation, when they go into the lymph node, there will be stampede. It's too much of cells in the lymph node, right? So that will destroy the cytoskeletal protein. Can anyone tell the cytoskeletal protein of a mesenchyme? Here is just written cytoskeleton, but I can actually tell the cytoskeletal protein of mesenchyme, that is vimentin. It destroys vimentin. The vimentin, once it's destroyed, it becomes weak, and once you smear it, it gets damaged and becomes smudged. A very, very good reasoning why question for CLL, right? So you know, all these cells go inside, that stampede will destroy the vimentin, the cell comes out, they are weak, and when I press and make a smear, it gets destroyed, right? Vimentin destruction causes that. In single word, it's due to destruction of vimentin, the cytoskeletal protein, right? Perfect. Great. So now, we know the CBC findings, we know the peripheral smear findings. One thing I have told you, which you can again use as a template for every lymphoma in the lymph node. Do anyone remember that? There's one finding in the microscopy of a lymph node. For every lymphoma, you can use it. Lymphoma is a tumor of the lymph node. So when the tumor cells come, they will destroy the normal architecture, which means cortex medulla, follicle, parafollicle, that will be destroyed, right? So whenever you look at any lymph nodes lymphoma, this word can be mentioned. Effaced lymphoid architecture. By whom? If I'm using the term small lymphocyte, CLL, mantle, follicular, marginal. All these are small lymphoid lymphomas. You can use the same thing, effaced lymphoid architecture by intermediate cells, Burkitt's lymphoma. Effaced lymphoid architecture by large cells, DLBCL. That's all is lymphoma, right? Effaced lymphoid architecture is very classical. Am I audible? I hope I'm audible. If not, do let me know. Hello. Okay, perfect. Thank you. Fine. So effaced lymphoid architecture is something which you can use for any lymphoma. Please use it for small lymphoid lymphoma also, right? It's going to be replaced by small lymphoid tumor cells, right? And this is diagnostic here. Proliferation center are diagnostic of SLL, right? So let's say these are small lymphoid cells. So if you want to draw a diagram, put a tiny box. Don't make it a bigger box. As smaller is it, that's more comfortable for you to draw, right? Put multiple dots and put a round area. Mark them as proliferation center. Proliferation center, if they ask in a Viva, what are they? These are the places where the tumor cells start dividing. The tumor cells divide here. That's the reason we call them a proliferation center. We have a particular type of cell here called as prolymphocytes. When they divide, they'll be immature, right? So the prolymphocytes will be very high in number in the proliferation center. That is diagnostic of CLL, right? That's what you see in the microscopy. Then marker. Every lymphoma, every leukemia, the diagnosis is on the IHC only. There's no way you can diagnose without IHC. You need IHC without fail, right? Almost every lymphoma, which is important for us, are B cell lymphomas, B lymphoid lymphomas, right? So I already know a statement. B cell marker 1920 is positive across every lymphoma, be it CLL, be it marginal, be it Burkitt's, be it your mantle, be it follicular, right? So first thing is for B cell. Every lymphoma is a B lymphoid lymphoma. There are few lymphomas which are T lymphoids. I'll mention that here as well, right? ALCL is T lymphoid, anaplastic large cell lymphoma. They might not ask you in an exam, just for us to remember. Mycosis fungoides is T lymphoid, right? The epidermotrophism and the cutaneous T cell lymphoma, right? And adult T cell leukemia lymphoma. That's good because in the name itself I have adult T cell leukemia lymphoma. The only thing which I can expect in a second year with adult T cell leukemia lymphomas, it is associated with a virus called as HTLV1. That's the only thing which can be coming in an MCQ or a Viva. These are T lymphoid lymphomas. They'll be positive for CD3. We know T cell, we know B cell, we automatically can make a statement here, right? Okay, perfect. So we know B cell lymphomas and as a classical marker there. Then I have come to specific marker. Specific marker, I have two markers here. That's a marker for naive B cell, right? CD3 and CD23. If markers are confusing, go back to the Nischay batch or the PW lectures, watch once B cell journey. It will make much more sense now than at the time of reading WBC. Markers will not be confusion. If you feel like, okay, I can memorize it, memorize it. I'll leave it up to you, right? Naive B cell markers are CD5 and CD23, they'll be positive, and 19 and 20 will be positive for your B cell marker irregular. That's IHC. So I can confirm the diagnosis easily. After confirmation, two things are must. Headings, complications and prognostic factors. Even if you don't remember everything, at least some is required, right? So complication, one complication, this can come in an MCQ, you should remember is Richter's transformation. CLL is a low-grade lymphoma, small lymphoid and a low-grade lymphoma, which can become a high-grade lymphoma, that is DLBCL, diffuse large B-cell lymphoma, right? It can become a large B-cell lymphoma. So all the thousands and 10,000 cells in the lymph node is becoming larger all of a sudden, twice the size. So there will be a stretching of the capsule. Clinical feature is very, very important. Sudden painful increase in size of the lymph node. Very classical. Generally, when we think pain in the lymph node, we won't think of lymphoma, we'll think of infection. But it's very important. In a patient with CLL, if there's a sudden painful increase in size of lymph node, suspect transformation. Why? It's painful because the cells are becoming double the size and the capsule is being stretched all of a sudden. It will become painful by default, right? Suspect a Richter's transformation. It's nothing but CLL becoming DLBCL. Here the prognosis drops like anything. Within 12 months, 8 months is what will be the prognosis. It drops a lot when it becomes DLBCL. Fine, perfect. Now let's go to prognostic factors. See, CLL is a leukemia, right? Before going to prognostic factors, few things to learn and then we'll go to prognostic factors. CLL is a leukemia of the lymphoid circulation, right? Can I say if it's leukemia, bone marrow might have cells there? They might have cells in the bone marrow, the tumor cells in the bone marrow, right? I'm a leukemia from the lymphoid circulation. So if I occupy the entire bone marrow and reduce the RBC production, reduce the platelet production, good or bad? Just tell that. Let's understand why we need to know the prognostic features so that we not memorize it. Obviously, it is bad. A leukemia going in, finding or taking the place of an RBC, taking the place of a platelet is not good. It is bad, right? Which means a bone marrow involvement diffusely. Only when I diffusely involve bone marrow throughout, I will not be able to give space for RBC and platelets. Then a patient having anemia plus CLL, bad. A patient having anemia, thrombocytopenia plus CLL, bad. Because I'm not giving space for anything else, right? That's the first thing, right? So Rai and Binet is a staging classification, can come in an MCQ. Advanced stage is bad, early stage is good. It's not a rocket science for us to remember. The staging is based on these two parameters. Anemia and thrombocytopenia present, which means the bone marrow is occupied by the tumor and there's no space at all for me. Bad prognosis, right? Bone marrow involvement is of diffuse type. Entire thing, when it's involved, I won't have space for the others, right? If I involve patchily, I involve intermediate some places, I have space for others. Again, a bad prognostic factor, right? This you can generalize everywhere in the tumor cancers. This you can generalize in almost every blood-related cancers. P53 is the worst. Be it in the breast, be it in the colon, be it in the WBCs. Any cancer, P53 is one of the worst mutation for us to have, right? So deletion of 17p, which is deletion of P53, the guardian angel, bad prognosis. Deletion of MLL gene, deletions involving 11q23 or translocations involving 11q23 is bad with respect to leukemia because it will make the neoplasm chemoresistant. I'll give chemotherapy. When this gene is altered, my chemotherapy will be not working for us. Fine. Then ZAP70, it provides a growth factor. So more the ZAP70 is bad for me. And lack of somatic hypermutation. Somatic hypermutation is the go for almost every non-Hodgkin's lymphoma. That's a common pathway. That's what I said in the starting. If you don't know something, put chromosome 14 related translocation. That is somatic hypermutation. If I don't have that, I have a problem, right? In an exam, I don't want you to write this, but this is just for us to understand. If there's a question which comes, enumerate good and bad prognostic features. Put a table, remember one, exactly opposite the other one. That's all. Rye and Binet, early staging, good prognosis. No anemia, good prognosis. No thrombocytopenia, good prognosis. That's all. No. You have bone marrow involvement, which is not diffuse. Sparse involvement, good prognosis. Every other translocation you know, apart from these two, good prognosis. Or absence of p53, good prognosis. Right? Or having somatic hypermutation, good prognosis. Right? So this is just for us to understand. Don't write this exam. That's how you're going to write the prognostic features for almost every disease. Clear? That's in short about CLL, a chronic lymphoid leukemia and a small lymphoid lymphoma. SLL will not come in an exam. If it comes, almost exactly the same. But SLL, ignore this guy. SLL will not involve the blood. It is lymphoma which will involve the lymph node. Write this part alone. Be a little bit cautious. Read the question. If it is CLL bar SLL, write everything. If it is only SLL, ignore the smut cells, ignore the CBC finding, write only lymph node, rest everything remains the same. Okay? If it's only CLL, again write everything again. Fine? Perfect. Now let's go to the next guy. Anish, see you after a year. Come back soon. Okay? The next tumor is mantle cell lymphoma, right? I said there are 4 important lymphoid neoplasm in small: mantle, follicular, marginal, and your CLL, right? So mantle cell lymphoma is a lymphoma which comes from the pre-germinal center origin, right? Mantle is a pre-germinal center neoplasm. I have told you we write MANTLL like 11. It looks like 11. If you write in small letters, it looks like 11. The reason is it involves translocation 11-14, right? Like 11, 11-14. Like I said already, chromosome 14 is always the common person. It will be there in mantle, it will be there in Burkitt's, it will be there in your follicular, it will be there in almost every non-Hodgkin's lymphoma, right? What happens in this 11-14 translocation is 11th chromosome, I have a molecule called as cyclin D1. The cyclin D1 which is present and that will be overexpressed. And what's the purpose of cyclin D1? Cyclin, cell cycle, right? It derives it from the name of cell cycle. So cyclin D1 is more, it pushes all the cell from G1 to S phase. If you remember your cell cycle, you must have read in your UG days, right? In your school, we have checkpoints in cell cycle, right? So G1 to S phase will be easily pushed. So they'll have more and more proliferation of cells from G1 to S phase, right? So when this happens, automatically I'll result in the tumor formation. That's the pathogenesis or the carcinogenesis. As simple as that. Okay. Just to make sure that your concepts in neoplasia is fine, I'm just going to ask you a question. Let's see how many of you can answer it. Ready? You know the pathogenesis, right? Can anyone tell me cyclin D1 here, is it a proto-oncogene or a tumor suppressor gene? Let's see how many of you can answer that. Cyclin D1, is it a proto-oncogene or is it a tumor suppressor gene? You know the answer. It's a proto-oncogene because it is going to promote the proliferation. That's why it's being overexpressed in case of your mantle cell lymphoma. Fine? Perfect. So now let's come to the clinical symptom. Same clinical symptom. This is something which is completely common. Adult generalized lymphadenopathy, that's how nodal mantle cell lymphoma presents. Right? Now, extranodal manifestation is something which is unique for mantle cell lymphoma, which we have to know about it. Fine? Extranodal, see, generally, if you remember this, that's more than enough. You will have a finding called as lymphomatoid polyposis. Here, the answer is reasoning why question. The question is, why do I have a lymphomatoid polyposis in mantle cell lymphoma? The answer is simple. If you take the intestine has something called as submucosal lymphoid aggregate. Can anyone name that? We have submucosal lymphoid aggregate in the intestine. Can anyone name that? Why do I have lymphomatoid polyposis in mantle cell lymphoma? If a reasoning why question comes, we call them Peyer's patches. When these Peyer's patches are getting involved by a relatively slow growing tumor like a mantle cell lymphoma, it becomes big. It becomes big. It becomes big. Anything protruding from your skin or mucosa, we call it a polyp. That's it. That's all, right? So what happens here is the Peyer's patches will be involved and produces a polypoidal projection. It produces a polypoidal projection and we call them lymphomatoid polyposis. Why is it important? Whenever as a surgeon, if some surgeon sees a polyp, he'll always think of an adenoma. They won't think of a lymphoma, right? So just to keep in mind, to avoid the misdiagnosis, we have to know that GI presentation of mantle is pretty common and they present as polyp, that is a lymphomatoid polyposis, because lymphoma is a medical management, not a surgical management. That's the reason this point is very important for us to remember, right? So we know one reasoning why question as well. So we know the clinical features. What do we see in CBC and PS? Generally, CBC and PS is normal. Very rarely I'll have the mantle cell lymphoma coming in peripheral smear, because a lymphoma, it's not a leukemia. But your lymph node will definitely have finding. Same, we'll start the template always with the same. Lymph node, in the early stages of the lymph node, what I'll have expanded mantle zone, right? Mantle zone alone will be expanded, that's all, in the early stages. In the late stages, we already know the template, right? Effaced lymphoid architecture by small lymphoid cells. Same thing what we saw in your CLL. The same thing I'll see here also, right? Initially, mantle zone expands and all these mantle zone fuse and completely becomes uniform, replaced by small lymphoid cells. Then how do I identify? By markers. Same routine. I know it's a B cell lymphoma, so I know B cell markers, right? Then CD5 will be positive here, CD23 will be negative here, but the most important guy for us is this, cyclin D1. Cyclin D1 is the most specific marker because that's the pathogenesis. If you have to remember one marker, remember the marker linked to the pathogenesis, because 1920 is non-specific, right? That's common anywhere. 5 again, CLL also has it, but this is very unique. Your cyclin D1 is the most specific marker for mantle cell lymphoma. This came once in an AIMS exam. If at all it repeats or they ask in a Viva, cyclin D1 can be negative in mantle where SOX11 marker will be positive, right? Then prognostic factor. One of the worst prognosis, we have a variant called blastoid mantle cell lymphoma. Here you will have the same bad guy, p53 loss, and because of that there will be an excess division. Not just excess division of the tumor, it also can spread. It's blastoid, like a blast, which means it's going to enter the bone marrow and enter the blood. Only in this condition, mantle cell lymphoma may have a CBC finding. Otherwise, CBC is completely normal in mantle cell lymphoma, right? As simple as that, right? Very simple. Same origin, pathogenesis, your clinical features, microscopy, marker, prognosis, and your complications, right? 5-mark question, this is more than enough. Almost everything required, almost everything the doctor who corrects knows. See, they won't know if you write 10 mutations. Trust me, they won't know. They will know only one which they use clinically for them. That is cyclin D1. If you write that, they know it. If you write, I read in Robbins or any other book, there's 10 extra mutations. It doesn't matter for me. For me, what matters is, okay, these points are there, the headings are there, the actionable targets are there, enough for me. Fine, perfect. The next one is follicular lymphoma. Same routine. Follicular lymphoma is a germinal center neoplasm, especially they arise from centrocyte. There are two cells in germinal center. One is centrocyte, other is centroblast. They come from centrocyte. Follicular, again we know, one guy is common, which is 14, which is common, right? Here, what happens is translocation 14-18. 14 we have immunoglobulin chain and 18 we have your BCL2. So what happens in this translocation is BCL2 gets overexpression, right? We'll move this a little bit away. Can anyone tell me where did you guys read BCL2 before? You must have definitely read BCL2. Where did you guys read BCL2 before? BCL2 is a gene which you must have read in apoptosis, right? BCL2 is an anti or pro-apoptotic gene. You know the answer. Anti-apoptotic gene, pro-apoptotic gene. BCL2, whichever has L, has a longer life, which is an anti-apoptotic gene, right? Perfect. So when there's an overexpression of BCL2, what happens is there is more and more and more anti-apoptotic effect, which results in longer life of any cell. That's a problem in case of a follicular lymphoma, right? So you'll have overexpression of that, which results in longer life. Whenever it's longer life, it will automatically keep on accumulating new mutations. That's by default the problem, because you live for 150 years, you'll make mistakes, right? One of the important mutations is this guy, KMT2D mutation, that is seen in close to 90% of the cells of follicular lymphoma. As of now, not using them for diagnosis. Maybe in future we might target the mutation also, right? So there's a very classical mutation which I want you to remember, that results in tumor. Because the longer life is the basic pathogenesis, that gives the slow growing nature of it. Okay, the slow growing nature of the tumor is due to the longer life being the primary cause and not the increased cell division being the cause, right? And here the most important thing is the most common indolent lymphoma. Indolent is very, very, very slow. Okay, it's the most common indolent lymphoma, which I want you guys to remember, right? Clinical features. If the most common indolent lymphoma, very slow growing, generally they don't spread, right? Stays in a single group of lymph node. You might have generalized lymphadenopathy, but mostly very slow growing. Will have history for years together, okay? But the problem is it's slow growing. If something is slow, we don't care about it, right? We'll say, we'll look at the last. Same problem, na? We read second year for 1 year, but when are we more concentrated? Close to the exam. At the start, we have 12 months. Now we have only 12 days, right? When slow growing, we don't care much about it. So it grows big and it can spread to the bone marrow, can come to the peripheral smear. Because of the slow growing nature, most patients ignore them, and more than 2/3 present with bone marrow metastasis. That's a very, very classical finding. We have not read about bone marrow metastasis in mantle. It's a bit aggressive than this. Again, we don't read them often. Only in blastoid it will happen. But here, 2/3 of the patient present with bone marrow metastasis can present with anemia. And in bone marrow, there's a very unique way of presentation. It's called an paratrabecular presentation of the metastasis, right? Which means the tumor cells will accumulate in the paratrabecular area. If you have a bone marrow like this, I have a bone marrow trabeculae here. If you want to draw a diagram, you have all these lymphoma cells arranging in the paratrabecular area. That's a classical finding for follicular lymphoma, paratrabecular involvement, right? Now let's get the microscopy of lymph node. Same effaced lymph node architecture. Before that, what I'll have follicles, which is going to replace the entire cortex and medulla. I'll have increased number of follicles. And the most important thing, please write this, which is very important. The follicles are mostly of similar size and shape. It will not be exactly identical, but similar size and shape. If the follicles are very different size and shape, it is reactive. Because reactive also can have follicular hyperplasia. It's very important. In the later stages, I'm going to have the same thing. Effaced lymphoid architecture with small lymphoid cells. Why this similar shape is important is, if they are of varied shape follicles, it's a very important clue for me to call them as follicular hyperplasia, which can be seen in infarction. When you have a sore throat, follicles will become more, right? That will be varied follicles. It will not be similar, right? And one more important thing, in high power, in case of follicular lymphoma, in high power, what I see is, you will see centrocytes. Okay, centrocytes is a very unique appearance. They'll have folded nuclei. The nuclei will be folded and have nucleoli. That's very, very classical. Folded or cleaved nuclei is a classical finding for centrocytes, which you see them only in higher power. You won't see them in low power. These two I want you to add here. Fine, perfect. That's for follicular lymphoma. Markers the same way. We are not going to change our template at all. B cell marker 1920. The most important marker is the marker related to the pathogenesis, that is BCL2. That's the most important marker without fail. Okay, BCL2 is the most important marker. Fine. These two are also positive, but again, if you write, great. If you don't write, I won't mind, because these are germinal center markers. They are positive by default, right? And they are 5 negative, 23 negative. To differentiate from other small lymphoid myoplasms, they are negative for it, fine? So that's about follicular lymphoma. This also can progress to DLB cell. That's one of the complications of follicular lymphoma, fine? Done. So we know about follicular lymphoma, we know about mantle cell lymphoma as well. Fine. So we saw CLL, we saw mantle, and we saw follicular lymphoma. Now let's go to the next big guy, bucket. Bucket has all the things to be asked for an essay question. A very easy clinical scenario which we expect undergraduate to at least know this, right? An African child, swollen jaw, EBV positive tumor, think of buckets. Starry sky in the microscopy, think of buckets. Something which I want everyone to know. So the exam paper setter is a good person. At least the basic things you have to know. This will be in your long answer question. So do listen to it. Fine. Burkitt's lymphoma. Someone said the mnemonic before, right? It's BUC8 lymphoma because 8th chromosome. It's a intermediate cell type neoplasm. It's not a small lymphoid. It's an intermediate lymphoid neoplasm. It also arises from germinal center, but from centroblast. They are not centrocyte. They are from centroblast. It's BUC8. Before going to the pathogenesis, we divide the etiological group into two. We call them endemic bucket and we call them sporadic bucket, right? Endemic bucket was seen mostly in Africa, and the most common site is your mandible, the jaw, right? Endemic bucket is 100% associated with your Epstein-Barr virus, because in Africa the virus is so endemic, almost everyone will have the Epstein-Barr virus infection. So with bucket or without bucket, the prevalence is very, very high, right? Sporadic bucket can be seen anywhere in the world. The common site is not mandible. Sporadic bucket can be nodal as well as extranodal. If it's extranodal, can present as GIT as interception. It can be in the node or it can be in extranodal. And sporadic bucket lymphoma is also EBV positive, but it's not 100% EBV positive, right? That's the difference between endemic bucket lymphoma and a sporadic bucket lymphoma. Fine. Okay. Done. Fine. Great. Then the etiopathogenesis. See, Burkitt's lymphoma, like I said, it's BUC8. It's the 8th chromosome, which is the problem. It can translocate with 814, it can translocate with 822, or it can translocate with 28. The partner chromosome might change, but the important chromosome is 8th chromosome. What happens is, actually EBV induces the proliferation of B cells. EBV enters the B cell via the receptor CD21 or CR2. It induces the proliferation. The more faster it divides, there's a chance of an error. That error is the translocation. Once a translocation happens, I have c-MYC, which is there in the 8th chromosome. That is be overexpressed. c-MYC is notorious because c-MYC activates Warburg's effect. Do you guys remember Warburg's effect? That's the one which will make my cell a stem cell. It will keep on dividing, right? So once a c-MYC is more, it will increase the Warburg's effect, which will increase the proliferation of the cells. To an extent that every cell will keep dividing. That's why Ki67 is close to 100%. It's 100% Ki67. The no tumor in the world has 100% Ki except for Burkitt. That produces a classical Stargardt appearance. That's my pathogenesis. Fine. So you know the pathogenesis? Microscopy. Microscopy in the lymph node. Here you can write the phase lymph node architecture, but I would say put the word Starry sky first. Then the second word you can write, there will be phase lymph node architecture. What is Starry sky? I might want you guys to draw a diagram here. If it's an exam, put round tumor cells, clear areas in the center, right? Starry sky, the tumor cells are the sky, and the clear area, the macrophages are the tingible body macrophages, which is the stars. The macrophages are the stars and the tumor cells are the sky. The macrophage name is also called as tingible body macrophages, which are nothing but normal macrophages which are fed up eating the tumor cells. They are dying. I'm eating them fast, so I'm becoming fat, looking like a star in a blue background. That's a classical starry sky appearance, right? Burkitt's, since it's very, very aggressive, there's a very likely chance it can go to the bone marrow. Right? It can easily go to the bone marrow. The moment Burkitt's lymphoma goes to bone marrow, we call the blast Burkitt blast, or the older name also is there, which is L3 blast. L3 blast is the older name. The newer name, we don't call it L3, we just call directly Burkitt's blast. Fine. Burkitt's blast has a very unique appearance. Yes, Pravesh, you're right. Fine. Burkitt's has a very unique appearance. You'll have vacuolations in cytoplasm and you'll have a sky blue cytoplasm. That's the appearance of Burkitt's blast. But the most important thing about Burkitt's blast, which can come in a Viva, Burkitt's blast is generally lymphoid blasts are PAS positive and PAS negative. I want you guys to comment, then we'll go to the next. Lymphoid blast, PAS positive or PAS negative? What do you guys think? Lymphoid blasts generally are PAS positive, right? ALL blast are PAS positive, right? Which blast is SBB positive? MP1 SBB positive for myeloblast, right? This is unique. Burkitt's is a lymphoid blast. It's a L3 blast where PAS is negative and SBB is positive. Okay, they have PAS negative and SBB positive. That's unique. A normal lymphoid blast is PAS positive and SBB negative. Burkitt's blast is the ulta. I want you guys to remember that, right? That's a classical finding of Burkitt's blast. Then come to markers. Markers are the only way we diagnose. Same. 1920 positive here also, right? The most important marker is the pathogenesis marker, c-Myc, positive here also. That's the most important marker for me, diagnostic marker, c-Myc. Then I have 10 and BCL2 positive. We saw in follicular also. This is germinal center marker. Tell the origin, that's all. And a very unique thing, they are Ki67 close to 100% positive. Okay. And if an image is given in an image-based question, if you are writing for a NEET PG, any IHC marker will have brown color, which denotes positivity. If everything is brown in color, I will call it 100% Ki67, which is positive here, right? One of the worst complications of Burkitt's is tumor lysis syndrome. See, Burkitt's is a double-edged sword. The tumor came, I should diagnose fast. If I miss the diagnosis, it will spread and metastasize and kill the patient. If I diagnose fast, I should treat it. The problem is treating also. That's a tumor lysis syndrome, right? This is a treatment-related complication of Burkitt's. The moment you give chemotherapy, Burkitt's lymphoma melt with chemotherapy, which will kill millions of cells at the same time because chemotherapy acts on the dividing cells, right? You remember pharmacology. We call them cells which act on the cell cycle, right? Topotecan, irinotecan, mitotic spindle inhibitors, right? They act on the cell cycle. They act on the DNA polymerases, right? That's how they act, right? They destroy them and they destabilize the cell and kill the cell. So here in Burkitt's lymphoma, 100% cells are in cell cycle. Millions of cells are in cell cycle. When all of them are killed, what happens? You'll have tumor lysis syndrome, which will result in hyperkalemia. Because calcium is the most common intracellular ion, right? Then you'll have hyperphosphatemia. Phosphate is an intracellular buffer that will come outside. Phosphate binds with calcium in the extracellular space, right? Sorry, this potassium is a most common intracellular ion, right? So that will cause hypocalcemia. And I'll have acid-base disturbances because bicarbonate buffer is also there. You'll have acid-base disturbances, and when I destroy a nucleic acid, you will result in purine destruction. Purine metabolite is uric acid. You'll have hyperuricemia. So all these are features of tumor lysis syndrome. Do remember that. Fine, perfect. It's a very difficult disease to treat. If I treat early, I have a complication of tumor lysis syndrome. If I treat late, I have a complication of metastasis, right? But if tumor lysis can be managed properly, Burkitt's is a decent prognosis, fine? Okay. Again, one more complication is Burkitt's can also become DLBCL. That can progress to DLBCL. That also is a complication of Burkitt's lymphoma, fine? So that's in short about Burkitt's lymphoma. We know about Burkitt's, etiology, sporadic, endemic. We know the pathogenesis. EBV comes inside, EBV proliferates, EBV causes the mutation, and the mutation causes the tumor. Then we know the we know the microscopy in the lymph node, we know the microscopy in the blast, we know the marker, we know the complication as well. Done? Perfect. Great. Okay. Before going to the next question, I'm going to ask a simple MCQ which came in the NEET PG exam before. Let's see if you guys can answer that. Though it is not a pathology related MCQ, I'm going to try. I know you guys can do it. Can anyone tell me what is the most important step in treating the tumor lysis syndrome? Tumor lysis syndrome is inevitable. You cannot stop it, right? What's the most important treatment for tumor lysis syndrome? Anyone? Most important treatment for tumor lysis syndrome? Maintaining the hydration and the electrolyte imbalance. Plus, obviously, your allopurinol, everything will help, right? I have to maintain the hydration and make sure electrolytes become normal. Only then I can think of hyperuricemia because electrolyte imbalance can kill the patient, right? It can cause arrhythmia, it can cause heart block and everything, fine? Perfect. Next guy for us is Hodgkin's lymphoma. Hodgkin's, if I'm the examiner, I'd want you to know about Hodgkin's lymphoma, right? Because Hodgkin's is something which will keep on coming till your internship, post-internship, you start practicing. You might see patients of Hodgkin's, you might need to refer. It'll again come in an entrance exam, right? Hodgkin's, same template we're going to follow. Hodgkin's originated from the germinal center, right? Exactly, WHO calls it a crippled germinal center origin. Why crippled is the tumor cell, when they are about to die, EBV or a mutation gives survival. That's what crippled germinal center means, right? When they are about to undergo apoptosis, which receives a growth factor, nuclear factor K beta, in the form of these two guys. It is rel proton coagene, not red proton coagene. Fine. Okay. Epstein-Barr virus or your rel proton coagene mutation kind of gives the just a hope for a dying cell. That's why I used them crippled germinal center. And because it is about to die and someone gave a hope, it will change its morphology, it will change its function. That's unique about Hodgkin's lymphoma. Fine. Okay. So nuclear factor K beta acts on a dying B cell, proliferates and transforms to Hodgkin's lymphoma. But this transformation is a problem. They don't behave as B cell. They behave as multinucleated RS cell. Right? Multinucleation is a characteristic feature of which cell? Which cell will undergo multinucleation? If I ask you, what is the origin of Langhans-Jain cell? What will you tell? What's the origin of Langhans-Jain cell? What will you tell? You will tell histiocyte, right? Macrophage. RS cell is a tumor Jain cell which behaves like a macrophage. Macrophage will start secreting, right? In Langhans-Jain cells, the epithelioid cells, they secrete interleukins. This also will secrete interleukins, right? So it transforms and behaves like a macrophage. Don't write this. This for understanding. That's why they don't have classical 1920 markers of B cell, because it's transformed to an RS cell, right? It's very, very, very important. Fine. Okay. So what is a tumor cell, which is important for me, is Reed-Sternberg cell. Has a classical outside appearance. It's binucleate with two eosinophilic nucleoli. That's very, very important. It should not be basophilic. It should be in eosinophilic nucleoli. If you're drawing a diagram, please draw pink color. Don't draw blue color. If you're not able to draw pink color, don't draw itself, right? Classical RS cell is a tumor Jain cell, a macrophage which secretes interleukin, which provides the background inflammation. It is very, very important. Diagnosis is not just RS cell. Diagnostic point is RS cell plus background inflammation is diagnostic. Without background inflammation, I cannot diagnose Hodgkin's lymphoma. That is very, very important for me for diagnosis. Fine. Okay. That's one, right? So now we classify Hodgkin's lymphoma. We classify Hodgkin's lymphoma into two broader categories. One, we call it a classical Hodgkin's lymphoma. Fine. Definitely there'll be OVR. Don't worry about it. The other, we call it an NLPHR or nodular lymphocyte predominant Hodgkin's lymphoma. These are the two main groups of Hodgkin's lymphoma. Classical Hodgkin's lymphoma, all will have classical RS cells. Classical RS cell marker is this. Never forget this. Please don't write this. Please don't write this. This is for your understanding. Right? 15 positive, 30 positive, PAX5. This should be mentioned without fail. Weakly positive. PAX5 cannot be strong. If it is strong, it is not classical Hodgkin's. Right? This is the marker for classical RS cell. All the classical Hodgkin's lymphoma will have the same marker. This is a marker for classical RS cell. There are 4 different types of classical Hodgkin's lymphoma. All of them will have the marker, right? Your nodular sclerosis, mixed cellularity, lymphocyte rich, and lymphocyte depleted, right? All 4 of them will have. Few words about each of them. So nodular sclerosis is the most common variant in the world, in the India also, right? So here is the most common variant of Hodgkin's lymphoma in the world as well in India. It has one of the best prognosis, fine, okay? And sclerosis is the hallmark feature. That's why the term nodules of sclerosis, right? Most of the time, they are identified in stage 1 or 2. See, because it is very common in the Western population, they have good health care. They identify them in stage 1 or stage 2, right? Amasida. Okay, Dagi. 20 and 45 is for NLPHL RSL. We'll come back to that very soon, fine? Okay. So, where were we? Yeah. And this is a EBV negative neoplasm. Nodular sclerosis variant is EBV negative. Rest of them, most of them are EBV positive. So do remember them. It's a unique finding, right? And they also present mediastinal mass equal to male to female ratio. If you want to remember, write that. But never forget this. Nodular sclerosis has a variant of Hodgkin's cell, RS cell called lacunar variant of an RS cell. Lacuna is an empty space. So, allow the outside Instead of having a pink cytoplasm, I'll have an empty space. What problem do you have, Kunal? If you can tell me, I will try to change it. Okay, you'll have a very clear cytoplasm instead of a pink cytoplasm of an RS cell, right? That's a classical finding of nodular sclerosis variant of Hodgkin's lymphoma. Background, I'll have lymphocytes, T cells, eosinophils, and macrophages will be seen in the background, and they are EBV negative, right? And the prognosis is definitely good. We'll look at the prognosis very soon in detail, right? For all the variants. Next is mixed cellularity. It is common in developing countries. With respect to this, India is not a developing country. In India, we have developed at least with respect to Hodgkin's lymphoma. Fine. It's EBV related. More than 50% of the cases are seen in stage 3 and stage 4. Don't memorize. It's a statement that when a country is developing, healthcare is not that great. I cannot identify early. I will always identify in the terminal stage. That's why they are picked up most in stage 3 and stage 4 cases, right? And here you have the classical bimodal age distribution seen in both young and elderly person. Elderly tumors are a bit more aggressive because 60 years old, 70 years old, right? Definitely the patient's immunity will be poor and obviously the tumor takes an upper hand. Here, microscopy, I'll have variants of RSL, you'll have classical RSL, and this is one of the important things, don't forget that. We have a cell called Hodgkin cell. We call them a mononuclear variant of Hodgkin RSL, which means it has a single nucleate, not binucleate, single eosinophilic nucleoli also. That's classical. We call them a Hodgkin cell. Fine. Background, all of these cells will be seen. Plasma cell, macrophages, eosinophils, T cell, everything will be seen. Lots of cells, lots of mixture of RS cell and also mixed in inflammatory cell. We call it mixed cellularity variant of Hodgkin's lymphoma, right? The prognosis slightly worse than nodular sclerosis, but definitely a decent prognosis compared to the other two, right? Third and fourth, we have lymphocyte rich and we have lymphocyte depleted variant of Hodgkin's lymphoma. Okay, in lymphocyte rich variant of Hodgkin's lymphoma, see, one thing we know from the name, background, I'm going to have more of lymphocytes. Here, we won't have more of lymphocytes, lymphocyte depleted, right? In both the places, I'll have mononuclear variation of RS cell, that's your Hodgkin cell. Both are rare, and this is the rarest of all. Less than 1% of Hodgkin's lymphoma will be lymphocyte depleted. Why I'm having lymphocyte depletion? That will tell me the etiology. HIV destroys lymphocytes, and this tumor is HIV positive plus EBV positive. Both are EBV positive, but this is HIV positive also. That depletes lymphocyte. That's the reason I have less T cells in the background, right? External involvement is not that common in lymphocyte rich, but here it's a very bad. See, a patient is having a cancer along with a deadly infection. It will destroy the background. It will destroy the immunity. It will grow faster. It will destroy the RS cell also because HIV can destroy macrophage as well, right? So we have a variant called mummified variant of RS cell. We have a variant called pleomorphic variant of RS cell. Fine. Okay. They are being destroyed by the HIV virus. That's it. Fine. And this is the one with the worst prognosis. Lymphocyte depleted is the one with worst prognosis. I have an infection plus you have a cancer, right? Perfect. Jitu, personally, I would prefer KGMU. No, nothing against AIIMS Gorakhpur. Fine. RS cells, classical RS cells are seen in classical Hodgkin's lymphoma. All the 4 variants of classical Hodgkin's lymphoma, we'll see classical RS cells. Fine. Okay. All the 4 subtypes of classical Hodgkin's lymphoma will have the same positivity. CD15 positive, CD30 positive, and PAX5 will be weak. Whatever we saw, lacunar variant same, mononuclear variant same, mummified variant same, pleomorphic variant same. It won't change at all. Fine. Now let's go to NLPHL. NLPHL is unique. It's like every other non-Hodgkin's lymphoma. I have a classical origin, I have a classical pathogenesis, right? NLPHL, it's originating from germinal center, exactly from the centrocyte stage. It is not associated with EBV. 2 variants, no EBV. One is nodular sclerosis, other one is NLPHL. Both of them have amazing prognosis. Fine. They will have the REL proto-oncogene mutation. Nuclear factor K beta will be activated, which results in the proliferation, right? More commonly seen in young people, involves mostly a single lymph node. They don't spread. Single lymph node, they don't spread. Good or bad prognosis? Definitely good prognosis, right? Men has a little bit of more common involvement here, right? Centrocyte, in general, I told you, centrocyte will have a cleaved nuclei, right? That cleaved nuclei here made the appearance of the RS cell. We call them a popcorn variant of an RS cell. That's a very important finding. Popcorn variant of an RS cell is classical for NLPHL. We also call them lymphohistiocytic variant, LNH variant. We call them elephant foot variant. It's an imagination. Whoever imagines it to be, they gave the name for it. That's all. But popcorn variant of RS cell is diagnostic of NLPHL. Background, I'll have cells. If you've not noticed till now, I want you to notice and never miss this. Background of these cells will be purely B cells. I'll go back for classical Hodgkin's. Okay. Classical Hodgkin's, I'll have background T cells, be it lymphocyte rich, even in lymphocyte depleted, even your nodular sclerosis, we'll have background T cells. Even your mixed cellularity will have background T cells. It's very, very important. Only NLPHL will have a background B cell and rest everything will have a background T cell. The PDF will be there in PW Telegram channel and I'll put them in the WhatsApp group as well. Fine. Okay. See, soon. We'll come to that soon. We'll complete the class and we'll take a separate session for you guys. Fine. It will have a background B cell that is very, very characteristic because of pure B cell neoplasm. I'll have an RS cell, background will have B cell, nodules of the tumor will be there. That's the name. Nodular lymphocyte predominant Hodgkin's lymphoma. Fine. Okay. Markers. These are CD1513 negative. These are, some of you guys said, CD20 positive, CD45 positive, 19 also will be positive. Classical for B cell marker, right? It's a pure B cell neoplasm. At the same time, this will be 10 BCL6 positive also because germinal center origin. If you remember, write it. Great. If you don't remember, ignore it. And the most important thing, these are PAX5 strongly positive. This is very, very important. Not PAX5 positivity. PAX5 strong positivity is very, very important. That's classical for nodular lymphocyte predominant Hodgkin's lymphoma. Fine. And the treatment is also, I'll add one more thing. Because they are CD20 positive, I can add anti-CD20, rituximab. Along with ABVD regimen, you completed pharmacology, you know what's the treatment for lymphomas, add it to this. Along with ABVD, that's a classical thing for lymphoma, we add rituximab. That makes the prognosis better, right? With respect to prognosis, the best is NLPHL. Next is nodular sclerosis. And just to remember, both these are EBV negative. Rest everything is EBV positive. The prognosis keeps on dropping. The worst is lymphocyte depleted variants of Hodgkin's lymphoma. Fine? Clear? So we know all these different variations. Okay? Fine? So these are all the different important things with respect to Hodgkin's lymphoma. Hodgkin's can come in a long answer because it has good amount of potential to ask multiple subdivisions in long answer. I give a clinical history. I ask you what is the diagnosis, pathogenesis, the different types, and I can ask you write an extra note on the prognosis of the Hodgkin's lymphoma. Easily, I can ask it in a long answer question. Fine? Perfect. Now, let's go to the next guy, ALL. Okay. So we have ALL left, we have AML left, we have your CML, that's your chronic myeloproliferative disorder, and also we look at your plasma cell myelomas. Fine. Now let's go to ALL. I told something in the start. Can you guys remember? How do you pick up ALL? How do you pick up ALL? ALL, you pick up with the history of child having bruising and blast and a leukemia. Child with a leukemia is diagnostic of ALL. ALL is acute lymphoid leukemia. I'll have two different types of ALL. One is BALL and the other one is TALL, right? Perfect. Now let's go to it one by one. ALL is the most common malignancy in children. Okay. HIV will be there in case of a lymphocyte depleted variant of an Hodgkin's. Fine. It's the most common malignancy in the child, including throughout the body. Not just with hematological. ALL is the most common malignancy seen in children across all the tumors in the body, right? It has two different subtypes based on the lymphocyte. We call it T and BALL. Etiology, we don't have any classical clues. Like I cannot say that this is the one which caused it, right? But there are few radiations, carcinogens, which is important. Benzene, petroleum products, do remember them. That's one of the important risk factor for developing all the hematological malignancies, including ALL, radiation, and few inherited syndromes. See, Fanconi anemia has a problem in stem cell. Downs has a problem in multiple things, right? And your ataxia telangiectasia has a problem in stem cell. These all will increase the risk of leukemias. Again, this is not for one leukemia alone. ALL, AML, everything it remains true, right? Because there is a risk of leukemia because they have mutated stem cell. The origin of ALL is hematopoietic stem cell by default. Fine. Okay, perfect. So we have BALL and we have TALL. Both of them has a slight difference, right? If you look at them, both of them are seen in children only, predominantly seen in children, right? So BALL will have a generalized lymphadenopathy because B cell goes to the lymph node. TLL is mostly in thymus. They'll have mediastinal widening or a thymic enlargement. Children will have thymus and this thymus will be enlarged. That maximizes the, in chest x-ray, the mediastinum will become wider, right? BALL will have lymphadenopathy, right? Pancytopenia, this is something which is common for both. See, in both leukemias, bone marrow is going to be replaced by blast. No space for RBC, no space for normal WBC, no space for normal platelets. So there'll be more infections, there'll be more bleeding tendencies, everything will happen here as well, right? Okay. Lymphoblastic leukemia is leukemia, right? ALL is lymphoblastic leukemia, fine? Okay. So all these are due to the bone marrow involving by blast, fine? So mutations of BALL, PAX5, same thing what we read in your Hodgkin's. B cell is PAX5. T cell, the most common mutation is Notch mutation, right? So how do I diagnose them? Once you have a suspected patient with a fever, most of the leukemias are diagnosed incidentally. Patient comes for a fever, you take a CBC, you'll have leukocytosis, peripheral smear, you'll have blast. It's a microscopic diagnosis most of the time, right? CBC, you'll have leukocytosis, might also can have leukopenia, but most of the time you'll have leukocytosis only, fine? Rarely I can have other things as well, right? Then peripheral smear, how do you know it's a blast? It's a three-step process. The first one is I look at the size. Size should be at least 2 times or 3 times more than the size of an RBC. That is the most important criteria, right? 2 to 3 times the size of an RBC. That's the first criteria to say it's an immature cell. Second, to say it's a lymphoid immature cell. There should be no OR rods, no granules. I think of a lymphoblast. Third, nucleus of a lymphoblast is generally more darker compared to your myeloblast. They have a more dark and a condensed chromatin of a myeloblast than a myeloblast, right? So this is a microscopic finding. But people don't trust microscopy because I will say something is dark, you will say something is light. So then I come to marker. Marker is inevitable, right? So stains for confirmation. The first is PA stain. PA stains glycogen. That's what we read in the first chapter of Robbins itself, right? It stains glycogen, right? So these lymphoblasts will have glycogen which is unutilized, which will be positive here. But the pattern of positivity is very important. They'll have a dot-like or a blot-like positivity where you will have a blast here and the PAS positivity will be like a dot or like a blot, right? 1 or 2 tiny dots, dot-like positivity, diagnostic of a lymphoid blast. If I don't want this, I want a better marker, I go with your CD markers. That's how you pick up CD markers. CD markers, 2 things. CD34 is positive for every leukemia. TDT second is positive for lymphoid marker. It's a lymphoid marker. It's an immature lymphoid marker. Positive only in lymphoid leukemias, right? Okay. Fine. Anonymous. This is hematology. Okay. So hand mirror appearance. Yes, it's an important finding, but it doesn't matter it's not a diagnostic clue. That's all. Fine. Okay. So ALL has, apart from these two, I need to have subdivision markers, which is 1920 for B and 3 for T, right? If I know TALL, that's different, and BALL, that is different. Fine. Okay. Marker is the way to diagnose it. Fine. Perfect. Then we'll go to classification. The older classification is FAB. We don't use that anymore, but still most of the examiners expect an FAB classification. Do write them. We divide the blast into L1 blast, L2 blast, and L3 blast. L1 blast will be more or less homogeneous. All of them look uniform. Very good prognosis. L2 blast, heterogeneous, which means I'll have blast with a bigger one, a small blast as well, right? That's an intermediate prognosis. L3 blast, the Burkitt's blast we saw. Fine. It's involving the bone marrow, that's all, right? If it involves the bone marrow, it will expand the bone marrow, makes it very thin and becomes painful. Not for ALL, it's true for every leukemia, the bone pain and the sternal tenderness. Fine. Okay. So here it'll have cytoplasm will be sky blue. I'll have vacuolation cytoplasm in Burkitt's blast. I told that already. Burkitt's blast is very, very, very unique. It is PAS negative and SBB positive. Rest two lymphoid blasts are PAS positive and SBB negative. That's important for you to understand that. Fine. Okay. Okay, ignore this part. That's Hodgkin's part. Ignore that. Fine. So now let's come to the prognostic features. See, ALL diagnosis sorted, the microscopy sorted. How do I prognosticate ALL? Prognosis of ALL alone can come in a short note. Do remember them. Again, I'm going to talk about only one side. The other side will automatically know about it. ALL is a tumor of children, right? So obviously, if it's in an infant or if it's in an adult, you'll have a bad prognosis because the tumor is in child. That's all, right? Male gender will have a bad prognosis. The reason is simple because male have testes, right? All the best, do well. Fine. We have male is will have testes. Why it is important is testicular involvement will be a bad prognostic factor. We'll see that very soon why. That's the reason male gender has a slightly bad prognosis compared to female gender, right? TALL, because of the notch mutation, they have a bad prognosis because notch mutation increases the cell division so high, and TALL patients will have a total leukocyte count of more than 1 to 2 lakhs per cubic mm. It will be very, very, very high. So when it's very high, it's very difficult for me to kill the tumor. TALL also has more predilection to CNS and testis. Why these two organs are important is that's the reason male gender is bad for us, because these two organs have blood-brain and blood-testis barrier. You remember them in anatomy? So when I give a chemotherapy agent, the chemotherapy cannot change the blood, cross the blood-brain barrier, cannot cross the blood-testis barrier. So they are very privileged sites. The blasts go and stay there. I cannot kill them with chemotherapy. So once I stop chemotherapy, these blasts will come back to the circulation. Like they are hiding, that's all, right? Because the chemotherapy agent cannot cross the barriers, involvement of the CNS and involvement of the testis is really a bad prognostic feature. You have to remember this, right? L2, L3 classification bad, L1 is good. Total leukocyte count of more than a lakh, definitely bad. Fine. Okay. Tumors involving mediastinum, definitely bad because TALL involves a mediastinum. And the subtype of TALL itself is a bad prognosis, right? 17P, I already told you, very bad. 11Q, the same MLL gene I told you, very bad. And 922. See, 922 is a CML's translocation, right? If I see that in ALL, definitely a bad prognosis, right? And normal ploidy is a bad prognosis and a poor response to treatment. That's very, very important. The moment I give you chemotherapy, within 28 days, the blast should disappear. If the blast does not disappear with chemo, which means it is not responding to treatment, a bad prognostic factor by default, right? And add this as a uniform take for almost every blood cancer. Hyperdiploid is a good prognostic sign. Hyperdiploid means a cell with more than 50 chromosomes. I want you guys to answer only one. More than 50 chromosomes, the cell is good or bad? The cell is stable or unstable? It's not comparing L3 blast is Burkitt blast. Older name is L3. That's what I told in Burkitt's lymphoma, right? Older name of Burkitt's blast is L3 blast. It's a very unstable cell. If I have an unstable cell, when I give chemo, it is very easy to kill. That's why across every hematological neoplasm, when I have an unstable cell of more than 50 chromosome, hyperdiploidy, the prognosis is a bad prognosis. It's a good prognostic sign, right? Because it's an unstable cell, it's very easy for me to kill the cell with chemotherapy. So it has a good prognostic sign. Just a template to remember. Like 53P53 is bad, MLL gene is bad, hyperdiploid is always good. Fine. Okay. That's about your ALL pathogenesis. We saw only the worst prognosis. If they ask a comparison, write the good prognosis. Age between 1 and 10 years, good prognosis. Female gender, good prognosis. BALL, good prognosis. Absence of CNS involvement, testicular involvement, good prognosis. Notch is bad, so Pax5 is good prognosis. BALL is good prognosis. Right? Hyperdiploid is good prognosis. That's all. And absence of P53 is a good prognosis. Fine? Perfect. So now we know about your ALL as well. Okay, so we know about ALL, we know about few lymphomas, both your Hodgkin's as well as non-Hodgkin's, right? Now let's go to AML. Before going to AML, I'm going to ask you a few questions. Let's see if you guys can answer. Fastest finger first. See, AML, I don't expect them to ask much in detail about AML because AML is purely criteria based and classification based diagnosis. You have to memorize one classification. That's important in AML, right? But there's one type of AML which is very important, which is very unique, which can come as a short note. That is APML. Can anyone tell me what is the translocation you see in APML? Few questions. We'll discuss everything soon. What's a translocation which is seen in APML? Translocation seen in APML. This translocation 1517, right? That's very unique. There are few translocations where I don't want the 20% cutoff criteria. Very unlikely, Siddhi. If I have to extrapolate, I can ask APML alone. See, I can give a diagnosis of AML, right? And say 2 mark for classification, 2 mark for the markers and microscopy, and 4-5 marks for APML. That way I can ask. But generally asking the entire APML is a bit unlikely. Fine. Translocation 1517, translocation 821, inversion 16. These three were the cutoff for exceptions for the cutoff for blast criteria. This is an old one. In the new era, in 2026, what we see is almost every proven genetic abnormality is an exception for blast criteria. As on date, I don't want the 20% blast. Don't tell this in exam. I'm telling it for you for a NEET PG exams, fine? In an exam, we need to honor the whatever your traditional way of teaching is always there, right? So AML, it's an acute myeloid leukemia originating from common myeloid stem cell, like your common lymphoid stem cell for ALL, right? So we have classifications of FAB and your WH. WH is the latest. WH is what we follow, right? 2016 is what I have put here because that's what is there in Robbins. After that, there are 2 more updates which we don't want it for now, right? We classify them as recurrent genetic abnormality. Whatever I told, that's recurrent genetic abnormality, right? These 3 are the exceptions. 821, inversion 16, translocation 1517. Very good prognosis. Very favorable for 1517. That's the best of the AMLs, APML, right? Then we already know this. 11Q, we read in CLL as well as in ALL. Bad, no? Chemo resistance, poor prognosis. And AML with normal cytogenetics. The next category for classification is simple. I have one criteria, one classification for recurrent genetic abnormalities. Second, I have one more cancer, AML with MDS. Third, I have therapy-related AML. These are after giving you topotecan and irinotecan. These are called as secondary leukemias. If someone asks you, write a short note on secondary leukemias. When I give a chemotherapy for, let's say, breast cancer, that chemotherapy can cause more mutations and I can have second cancer, that is leukemia blood cancer, right? It's very common in patients who are cancer survivors. Both of them will have poor prognosis because imagine one person having breast cancer, then another cancer. Obviously, the body will not be able to take care of it, will have poor prognosis. 2 cancers, MDS, prior MDS or now having MDS. That also is bad prognosis by default, right? Then we have the AML not otherwise specified. This all is, as on date, all of them have intermediate prognosis. What are these? This is the old FAB classification. The M0 to M7, whatever we see, all these are old classification, which we don't use now. We call them AML not otherwise specified, which means the hospital does not have genetics, so they use on microscopy. So it's inferior to prognosticate, so we put all of them under intermediate prognosis. Fine, perfect. So how do I identify or diagnose AML? AML diagnosis simple, right? Same way, I'll have history says of pancytopenia, any age, comes to the hospital, take a CBC, look at a peripheral smear, I go the same criteria. Myeloblast, 2 to 3 times size of an RBC. They will have granules will be present, or rods will be present, and there's one more important structure called as phi body. That also will be present. Fine. So you can draw a blast, draw a big nucleus. They'll not be that dark as a lymphoid blast. They'll be a little bit vesicular. But the most important thing is they'll have rods. They'll have granules. Phi body is nothing but a very big granule. That's all, right? So these are OR rods. OR rods are nothing but They are nothing but the same lysosomal granule content, primary acidophilic granules, that's all, right? And the granules will be there, and these are darker granules which are 5 body. Okay, these are PAS negative because they don't have glycogen, they have been used up here. They are SBB positive. Reason, the granules have lipid membrane. SBB Sudan black, they are positive. And the best stain for me is MPO, because these granules are nothing but MPO, right? They are myeloperoxidase, the lysosomal enzymes. That's what is there in the granules. R rod is also positive for MPO. Granules are also positive for MPO. Fine. Okay. Perfect. Now, see, this is in general. Then how do I confirm it? Confirmation always for all the AML subtypes is based on marker profile only, right? Same way what we did for ALL. Okay. So you have, so this is for ALL. For AML, we'll go into different subtypes of AML. We'll have different markers. We'll look into that soon. Fine. So we have M0 to M7. M0 is undifferentiated. M7 is without maturation. Sorry, M1 is without maturation. M2 is with maturation. Maturation means site. CYT is maturation. Blast is immature. When I have less than 10% sites, right, like a promyelocyte, myelocyte, metamyelocyte, less than 10%, I call it AML without maturation. If that becomes more than 10%, I call it AML with maturation. AML M2 is the most common leukemia based on FAB classification, if it's based on microscopy, fine. Here, the first is undifferentiated. Here I don't even know whether it's lymphoid or myeloid. I'm stuck in between, right? It's not differentiated at all. It has a very, very, very early origin. It is not coming from common myeloid stem cell. It is coming from the pluripotent hematopoietic stem cell, like you can see here. Very early. I'm not able to differentiate yet. Okay? And then AML M3. We look at AML M3 soon in detail, right? AML M3 is acute promyelocytic leukemia, where you have this classical translocation. Very, very good if treated early, right? Then M4 is myelomonocytic. These both have a classical finding of chloroma. Never forget. Whenever a WBC tumor involves monocytes, normally also monocyte can become macrophage. It can go to the tissues. That is a general tendency of monocyte. In a tumor also, they can go to the tissue, can involve. We call it chloroma. I can have involvement of cutaneous involvement, skin. We call it chloroma. In the lymph node, we call it chloroma. Gum hypertrophy. Please put a star mark here. Not gum bleeding. Gum bleeding is a finding for reduced platelets. In any condition with reduced platelets, gums will bleed. But gum hypertrophy is characteristic of AML M4 or AML M5. Myelomonocytic or monocytic. Proptosis, classical for it, right? It can involve behind the eyeball. Classical for AML M4, M5, fine. Okay. M6, erythroid neoplasm. Very bluish cytoplasm because of the globin and has a very, very, very circular nuclei. Very classical. Megarythmic blast, AML M7, common in Down syndrome, commonly seen in children, and they'll have blebs in the cytoplasm, fine. And the most important thing for us is your AML M3. We'll look at all of them, but I'm going to concentrate much more on AML M3 alone, right? Acute promyelocytic leukemia. Because here, everything here is unique. From the translocation, it's unique. Origin is unique. They are not originating from blast. They are originating from your promyelocyte. They don't have blast in microscopy at all, right? Because of this translocation, the retinoic acid receptor alpha will not be functional. So vitamin A cannot function. Function of vitamin A is maturation. So what I'll have maturation arrest in the form of at the stage of promyelocyte. That's a classical thing which I expect in the answer sheet. Maturation arrest. It's not going to mature. So what happens? Lots and lots and lots of atypical promyelocytes will accumulate in the blood. And the atypical promyelocytes are very big. They have a huge number of granules, right? So these atypical promyelocytes, when they degranulate inside a small vessel, granules can go and cause endothelial damage and causes DIC. This also is very, very unique. No AML presents with DIC. The only AML which presents with DIC is APML, never forget. And microscopy is also unique, right? There are two findings here. One, I'll have a cell which has less granules, but the nucleus will be completely indented or cleaved. What's the shape of this nuclei? And the second, I might have a cell, but I'll have lots and lots and lots of OR rods, bundles of OR rods, right? Mohammed, I don't know Hindi. So if you have any concerns, do let me know. I'll try to explain it slowly. Fine. Okay. So this is your buttock shaped nuclei. That's a classical finding of APML. And this is your OR rods. Okay. Bundles of OR rods. This cell is called an faggot cell. Faggot is bundles. Faggot cell and buttock shaped cell are classical diagnostic points of APML, what you see in microscopy. Marker is also unique. This is the only leukemia which is CD34 negative because they don't start from the blast. They are CD34 negative, very, very, very unique, right? They are completely MPO positive, 1333 positive, but they are CD34 negative. Treatment is also unique. Here I don't give the regular chemotherapy what we give for AML, right? Here we give all trans retinoic acid, ATRA. What ATRA does? It really is a block, that's all. See, it's blocked at the level of receptor, competitive inhibition. I increase the substrate, that's it. That's all, right? So, promolysis automatically differentiates into neutrophil. I might have a problem called as differentiation syndrome. There's a side effect of ATRA, which is like ARDS. Just remember, will have a side effect. We can easily manage them. And I have one more treatment option, arsenic trioxide, which can go and destroy the promyelocyte very directly, right? This is very, very unique about AML M3. AML M3 alone can come in a long note. You have to remember about that, fine? AML M0, like I said in the start, you have originating from the pluripotent stem cell. Here, CD34, HLA-DR, everything will be positive, but the defining marker, see, TDT is lymphoid lineage, MPO is myeloid. That should be less than 3%. That's why it is undifferentiated. It's neither lymphoid, neither myeloid, it's just a blast. Very, very superficial, very, very early onset blast, right? That's AML M0, fine? Okay. M4, M5, I already told you, monocytes will go to tissue. Because of that, I can have chloroma as a classical clinical feature. And most common leukemia, incidence-wise, is AML. This is purely based on incidence because AML is the most common subtype of leukemia. And if it's frequent association, we go for AML M4, M5. And you'll have a kidney-shaped nucleus in case of AML and it's a lace-like chromatin. That's for monocytic, classical appearance of monocyte. And the marker-wise, if both MPO and NSE is positive, it's myelomonocytic. If only NSE is positive, MPO is negative, that is pure monocytic leukemia, right? Dr. Future, will it be enough to pass the exam? This should be more than enough. If you properly structure it, it will be really good for you to score well as well, right? Because these are all the important points which as an examiner, I will expect you to write in an exam, fine? Okay. If you can reproduce this, great. But there's too much of information here. I hope you will be able to do your best. Fine. All the best. Fine. And CD14 and CD64 are the CD markers for monocytic lineage. That also will be positive in case of an AML M4, M5. M6, remember this part alone. Rest not required. Hemoglobin A positive, AML M6. It's a pretty rare tumor. Like an erythroid blast, they'll have an extremely round nucleus and a bluish cytoplasm. Actually, cytoplasm here is blue in color. In the image is not clearly seen. They'll have a bluish cytoplasm that's classical for a erythroid blast. And they are PAS positive. Hemoglobin A you can remember, right? It's erythroid, which is hemoglobin A positive by default. Last but not least, acute megakaryocytic leukemia, AML M7. Common in towns. They also can present myelofibrosis. Unique. Because megakaryocytes can produce PDGF, platelet-derived growth factor. Obviously, MEX will produce that, right? That will cause fibrosis. That's the reason AML M7 can have fibrosis. If there's a reasoning why, it can come in this way. Why does AML M7 have myelofibrosis? Simple reason, it's originating from megakaryocyte. Megakaryocyte normally only produces PDGF, which can cause fibrosis. Here, I have too many megakaryocytes. So, too much of PDGF, so it can cause myelofibrosis, right? They'll have tiny cytoplasmic blebs that are diagnostic. Why? Platelets are coming out of it, that's all. Okay? That's more than Dr. Future. Okay, platelets are coming out of it. And the GP1B9, GP2B3A, what you read previously in the yesterday's class, that will be positive because it's positive for megakaryocytes, right? Your CD marker is CD41, CD61, they are positive for it. Fine. That's classical for AML M7. Fine. So we know all the important leukemias, what you have to remember about it. Fine. Perfect. Okay. Now we have completed acute lymphoid, acute myeloid, We know about non-Hodgkin's lymphoma. We know about Hodgkin's lymphoma as well. Next one, you guys are going to help me. It's the most easiest question of all. Everyone knows about CML, right? I'll ask you a few questions, answer, then we'll go and discuss CML, and last we'll look at myeloma. What's the translocation you see in CML? One of the easiest question, and trust me, the only translocation you might remember even after years will be CML's translocation only. What's the translocation? Translocation is Philadelphia chromosome translocation 922. Because of this translocation, there will be an overactive tyrosine kinase. That is the one which causes the proliferation, right? Classical presentation of CML is simple. It is elderly person, massive splenomegaly. Reasoning by question. Can anyone tell me why there is splenomegaly in CML? Anyone? Can anyone tell me why there is splenomegaly in CML? Anything? See, if you remember the starting of RBC disorders in the regular batch, as I told you, the stem cells are not seen only in the bone marrow. It's also seen in the spleen and it's also seen in the liver. When we were kids, when we were fetus, they are there, they are dormant, right? So stem cells which is there in the spleen as well as in the liver also will have the same mutation. They also will proliferate. Here the problem is the tumor divides in the bone marrow as well as divides in the spleen. That is why post-treatment, you will have shrinkage of splenomegaly. Dr. Future, that's something which I don't want you to answer. It's not due to increased destruction. Here, the spleen is a part of the pathogenesis. It's not about extramedullary hematopoiesis. Here, the spleen is a part of the pathogenesis. The tumor grows in the spleen. That's why post-treatment, spleen should reduce in size. If it is not reducing, not a good sign for me. Fine? Perfect. Now let's go back to this. You know this for sure. Origins from the myeloid stem cell. You'll have the classical Philadelphia chromosome, overexpression of tyrosine kinase. The fusion gene will produce the tyrosine kinase, which causes uncontrolled proliferation. That's all. Actually, everything proliferates, but WBC takes an upper hand in CML. That's it. Fine. CML should have leukocytosis. CBC should be more than 11,000. It can be 1 lakh, 2 lakh, doesn't matter. Should be more than 11,000. But without this, don't complete the CML's answer sheet. Basophilia is must. If you see increased basophil count at any point of time in any patient in future, it should be, you should think of CML only, right? And the patient history, elderly patient, massive splenomegaly, and the reason why we have splenomegaly is due to tumor proliferation. It's not due to extramedullary hematopoiesis. It's not due to destruction. Okay? PH chromosome is Philadelphia chromosome. Philadelphia chromosome, the short form is PH chromosome, if you ask for that, right? Okay? Fine. Done. Okay. Now, see, you don't want a bone marrow aspirate for CML. You see in the peripheral smear, okay, I have a very high WBC count, and then I'm just going to do a peripheral smear, that's all. Once you do a peripheral smear, you will see the classical finding. What's the classical finding of peripheral smear? You know that you'll have shift to left. We'll talk about that very soon. Once you have shift to left, it's more than enough for me. I will suspect CML, then I go for genetic diagnosis. Either I do a karyotyping, or I do a FISH, or I do a real-time PCR. I would prefer FISH or real-time PCR. That's much better than karyotyping. Karyotyping if the patient is not affordable. That's all. Fine. Okay. Okay. So what do I see in peripheral smear? This I want to avoid, but your Viva, they might ask you, you'll have the classical garden party appearance or a college girl appearance. Both means only one thing. All the cells will not be uniform. Like a party, every cell will have a different size and shape. That's all. I'll have a blast, I can have a promyelocyte, I can have a myelocyte, I can have a metamyelocyte, I can have band forms, I can have neutrophils. I'll have all of them, right? So you'll have all of them, but the most important thing, myeloblast should not touch 20%. If it touches 20%, I'll go to acute leukemia. It is not chronic leukemia. You know that for a fact, right? Every form will be present. This is what we call it shift to left. Okay, you have shift to left. That is classical diagnostic point for CLL. And Theoretically speaking, this is required. Okay. Theoretically speaking, is required. Practically is not required. Lab score will be reduced or 0 in case of CML. It's used to differentiate another condition which will have shift to left, that is from sepsis. Sepsis also will have shift to left. We have something called an leukemoid reaction or sepsis. In that condition also I'll have more of immature cell, because when I have infection, I'll definitely end up in having immature cells, right? So that is where you can have shift to left also. So we call them a lab score, a test leukocyte alkaline phosphatase, which will be elevated in case of sepsis and it will be reduced or 0 in case of CML. Not required diagnostically, but can come in a 2-mark or a Viva. Fine. Okay, that's about lab score. How to differentiate it, right? And since we know college girl, convent girl appearance is seen in CLL. I'm sure you know that. Fine. Okay. Now, once diagnosed easy, the only thing next for me is classification, right? CML has 3 phases. We call them a chronic phase, accelerated phase, and blast crisis. The recent WHO has made it 2-tier. Write this, then write what I say. Recently, WHO has merged these two, made it 2-tier, so it's easy for us to manage. That's all. Now we have chronic phase with risk of acceleration and blast crisis. That's all. First, we'll go the easy one. Blast crisis is not CML, it is ALML. That's all. It's acute leukemia, it's not chronic anymore. So what is required here is blast crisis should have more than or equal to 20% blast in bone marrow or peripheral smear or extramedullary blast. If you have blast outside the bone marrow, skin, nose, ear, gums, anywhere, it's blast crisis, or it's more than 20% blast, it's blast crisis. There's nothing but it's an acute leukemia. It is inevitable, and blast crisis has very, very, very poor prognosis. Fine. Okay. I'll answer it. Just give me a second. Okay. So in chronic phase, it's just the normal type of CML at diagnosis. Blast will be in the range of 5 to 10% and responds well to TKAs, tyrosine kinase inhibitor. This is nothing but your imatinib. TKA is a short form. I want you guys to know that. Fine. Sorry. The next is accelerated phase. Accelerated phase is a little bit advanced than a normal chronic phase of CML, where the WBC count is high. Platelets are either less than 1 lakh or more than 10 lakhs. Look at the important point. The important point is with therapy. The important point is with therapy, which means even after giving therapy, it's not working. Splenomegaly is there, increasing size or not reducing with therapy. Because in spleen, tumor is proliferating. Spleen should shrink. If it is not shrinking, problem for me. Or I have more than 20% basophil, 10 to 19. It should not touch 20. The moment it touches 20, I'm going to call it a AML or a blast crisis, right? In blood or bone marrow, or the TKA is not responding. How do I say not responding? The first 3 parameters. WBC count not coming back to normal. Your platelet count is very, very high or very, very low, or your splenomegaly is not reducing or still increasing in size, which means tyrosine kinase inhibitors is not working. We call them accelerated phase. Fine. And next is blast crisis. Fine. Treatment is simple. You know the treatment. Treatment is by default your imatinib, and the most important thing for treatment is follow up of the treatment with imatinib. Right. Treatment is imatinib. If it doesn't work, we have to go to the 2nd generation tyrosine kinase inhibitor. Does anyone know any of the 2nd generation tyrosine kinase inhibitors? Does you? Dasatinib and ponatinib. If it doesn't work, we have to move to dasatinib or ponatinib. And if everything is fine, at some point of time, bone marrow transplantation might help. Fine. Okay. That's about your chronic myeloid leukemias. Fine. Done. This is the last one. That's your plasma cell myeloma. Fine. Can anyone tell me what is Philadelphia chromosome? Siddhi asked me a question. Can anyone tell me what is Philadelphia chromosome? See, actually, the translocation is not called as Philadelphia. Okay? The tiny fusion gene, what is formed after the translocation, that chromosome is called as Philadelphia chromosome. Fine? Okay? It's a name given because of the diagnostic part. That's all, Siddhi. Okay, now let's come to plasma cell myeloma. The plasma cell myeloma or a multiple myeloma can come as a long answer question because it has every potential to come as a long answer question. A very disguised history. Elderly, low backache. You might think of bone disorder, osteoporosis, anything. Anemia in microscopy. CBC shows hemoglobin of 9 gram. You won't think of WBC disorder alone. You'll also think of hematological RBC disorder. So it's easy to confuse, right? An X-ray showing lytic lesions. Lytic lesion can come in myeloma. Lytic lesion can come in TB. Lytic lesion can come in metastasis also. Lots of differential diagnosis, right? What's your diagnosis? And the most important thing, I have multiple subdivision. Classify them. Write about the microscopic finding. Lots of them. Fine. Future, if I am the examiner, I don't expect you to draw because I want my doctors to think, not to be artists. If you can draw in places where it makes sense, it's great. Otherwise, no need. Fine. No, Siddhi, only for 922 you can use the term Philadelphia, not anywhere. Fine. Okay. Let's come back to this. Fine. The origin of plasma cell myeloma, multiple myeloma, it's going to come from the post-germinal center B cell. That's a plasma cell, right? But the most important thing, this has to come from the bone marrow. Multiple myeloma does not come in the lymph node. It has to be in the bone marrow only. Fine. You have multiple problems here. Hyperdiploid is one of the most common chromosomal abnormality. In addition to that, any translocation involving 11th chromosome. It could be 11-14, it could be 14-18, it could be 8-14. It should involve the 14th chromosome. That's all, fine. And based on this, there will be lots and lots of proliferation of your interleukin 6. See, what happens is a normal plasma cell will be converted to a neoplastic plasma cell by these mutations. To maintain the neoplastic plasma cell's proliferation, interleukin 6 is required. Maintains the cell division and maintains the proliferation. Okay. Interleukin 6, if you remember, it's also an acute phase protein. If you remember inflammation chapter. That is the reason your ESR will be elevated in myeloma. There's a reason of elevated ESR in myeloma. That's the same reason for rouleau formation in myeloma. Because rouleau formation is based on the fibrinogen molecule, right? The same thing for your, that's also because of interleukin 6 only. Interleukin 6 increases the fibrinogen, it's an acute phase reactant, and your fibrinogen will cause faster sedimentation and also will cause rouleau formation. Fine? Okay, perfect. So, clinical feature, elderly, bone pain and fatigue, that's all. Actually, CBC will be normal. Peripheral smear, most of the time will be normal except for plasma cell leukemia, which is a very aggressive stage. Fine. Mostly maximum LC is your rouleau formation. But if I see plasma cell leukemia, that's plasma cell more than 5% in the peripheral smear, has a very, very bad prognosis. But one finding I can see in peripheral smear is rouleau. Rouleau is a stack of coins. French rouleau, that's attached one to the other. That's not diagnostic of myeloma. It's also seen in myeloma. That's all, right? Okay. Before going to the bone marrow, I want to go to the criteria because diagnosis here is not based on microscopy. Diagnosis here is based on criteria based diagnosis. Draw the bone marrow, write about the bone marrow later because microscopy doesn't matter for me. The number of cells only what matters for me. I have three things in multiple myeloma: MGUS, smoldering multiple myeloma, and your plasma cell myeloma, right? So MGUS, see there are only three parameters here: plasma cell number in the bone marrow, serum spike or serum immunoglobulin amount, or CRAB criteria and SLIM criteria. Fine. Less than 10, less than 3, or no M spike, negative for CRAB criteria. It's a first stage. This is the most common subtype of plasma cell dyscrasia, monoclonal gammopathy of uncertain significance. This is an older criteria, more than 10%. The newer criteria is 10 to 16%, 60%. Fine. Your, see this 3 gram, not 30 gram. 30 gram per liter or 3 gram per deciliter. Whatever you want, right? Keep it consistent. Fine. 3 gram per deciliter, more than that, and still negative for CRAB or SLIM. Again, it's going to be smoldering multiple myeloma. The moment it becomes positive for CRAB criteria, it becomes multiple myeloma. Or SLIM criteria, it becomes multiple myeloma, irrespective of the number of plasma cells and the serum, spike or immunoglobulin levels. But I need the basic more than 10%. Definitely required, right? I'm sure you know what is CRAB criteria. Fine. CRAB is hypercalcemia, renal abnormality, anemia, bony lesion on an X-ray. It should be on an X-ray. We have discussed CRAB criteria multiple times, which means bone is gone, bone marrow is gone, right? and the calcium levels is causing electrolyte disturbances, and the kidney is also gone. This is a CRAP criteria, right? SLIM is the latest criteria, which also called as an biomarkers of malignancy, which is very, very important to know. Any one of SLIM criteria is enough for me to call it multiple myeloma. S stands for 60. That's why I'll go here. That's why we stopped with 60% in the new criteria. If it is 61%, I'll directly call it multiple myeloma. I don't want anything else. I don't even want CRAB here, right? More than 60, light chain ratio. We have two light chains, kappa and lambda. Normally the ratio is like 2:1 or 1:2. That's all. In inflammation, both kappa and lambda will elevate. Not only one, both will elevate. But in a condition where kappa to lambda is 100 or more, which means one light chain is 100 times more than another light chain. Very, very rare in a normal condition. Has to be neoplastic. That's light chain ratio, right? So it's 100 times more light chain than the other. It's unlikely to be an infection. Has to be a cancer. That's multiple myeloma. Third is M, SLIM, right? M is MRI. You have more than one focal lesions in MRI. We call it diagnostic. We'll lead to a radiologist. They'll be able to report that, okay, the focal lesion, which is as per the criteria, will report the focal lesions. More than 0.5 centimeter, bone marrow stromal lesions, these are focal lesions. And here, any one of these is enough for me to call them a multiple myeloma. Either 60% or the light chain ratio or MRA more than one focal lesions, I can call it a multiple myeloma. I don't want a microscopy in this era. But if they ask what will be the bone marrow findings, we should be ready to answer about the bone marrow findings as well. I can have normal plasma cells. I can have binucleate, I can have trinucleate plasma cell, multinucleate plasma cell, right? This is not the exact Mott cells. Mott cell will have lots and lots of grape-like clusters in cytoplasm, right? You can have a Mott cell. You can have a Russell body with an intracytoplasmic inclusion. You can have a Dutcher body with an intranuclear immunoglobulin inclusion. Again, all these are just variations. This variation doesn't matter. Even if I have only normal plasma cell of 61%, it's multiple myeloma. It doesn't matter, it should be like this. It can be seen, that's all. Fine? Okay. There's a concept called as flame cell. Flame is like you'll have the immunoglobulin secreting outside. It is more commonly seen in IgA septa of multiple myeloma, just for us for understanding. Fine? And we already read about Roulet formation, right? Microscopy is not important for me. The criteria is important for diagnosis of multiple myeloma, right? Apart from this, we also have your serum electrophoresis. IHC again is not required, but I want you to remember these two guys at least. 38 and 138 are plasma cell markers. If I'm struggling to identify plasma cell, I can use them. But you can easily identify plasma cell. That's not a big deal at all. Serum electrophoresis. This can alone come as a 2 or 3 mark question. 5 mark, unlikely. If a university has 2 or 3 mark, they can ask it. Normal serum protein electrophoresis. In a normal person, you and me, this is the mnemonic, right? We have albumin, right? You have alpha 1, alpha 2, beta, gamma globulin. That's the normal serum electrophoresis. Fine. Alpha 1, alpha 2, beta, and gamma are globulin. And the gamma globulin is your immunoglobulin. Normally, that's the amount of immunoglobulin I can have normally. Albumin is definitely higher than globulin entirely, right? But if gamma globulin spike is equal to or bigger than albumin, I call it an M spike or a monoclonal spike. It just tells me the amount of immunoglobulin in this person is very, very, very high. Suspecting myeloma. Not enough for me. I have to prove monoclonality. What do we do? I take that gamma globulin alone and I redo electrophoresis. That's called as immunofixation. So what immunofixation does is, it'll do like this, right? It'll exactly differentiate, okay, is it A, is it M, is it kappa, is it lambda? It'll exactly tell me, okay, if only kappa and lambda, IgG and kappa seen, IgG kappa myeloma. If it's only IgM and lambda seen, IgM lambda myeloma, right? Immunofixation exactly gives the subtyping of myeloma. What myeloma, it'll be able to exactly tell me, fine? Okay. Rarely, up to 3% of multiple myeloma are non-secretory, which will be -1 electrophoresis, -1 immunofixation, fine? Yes, Colty. Okay. If you want to add on to the prognostic classification, IPS is a prognostic classification. At least remember this because this came once in a NEET PG exam, can come in an MCQ for you. Serum beta-2 microglobulin is one of the important parameters based on which we can classify the stages of multiple myeloma. If it's 3.5 to 5.5, it's intermediate. Less than that, good prognosis. More than that, high risk. Albumin, only two things. In between, right? Any level is okay for intermediate. If it's more than or equal to 3.5, low risk. Less than that means albumin is being less and globulin is becoming more, which means my liver also is struggling for it, right? So that makes it a worse prognosis factor. Fine. Okay. Perfect. That's about multiple myeloma. Additional thing, I want you to just answer about, write a little bit about the treatment option. Can anyone tell me what's the treatment for multiple myeloma? You might have heard about a drug called as bortezomib. I think it's bortezomib. That's useful for multiple myeloma. Add on to that if required, right? So that's in short about multiple myeloma. So what we have done in the past 2 hours is we have looked at non-Hodgkin's lymphoma, we have looked at Hodgkin's lymphoma, we have looked at ALL, we have looked at AML, CML, and multiple myeloma. This covers most of the things with respect to WBC disorders. Last few minutes, over to you. If you have any questions, do let me know. I'll be more than happy to answer them. See, presentation is the key to score in an MBBS university exam. Concepts is required, subject is required, but presentation is very, very important. Clearly, categorically, think for 1-2 seconds and then start writing. Don't look at the paper and immediately start writing. Think for a few seconds, structure how you're going to do and go ahead with it, right? Yes, proteasome inhibitors. I think, I forgot the name of it. I think it's bortezomib. If I'm wrong, please change it. It is very, very interesting, RKP. I work majoritarily on daily basis AI. This entire PPT is made by AI. I didn't make anything. I just gave the input. That's all. Daratumab. Okay, great. Fine. I think daratumab is another action of mechanism of action. I forgot it. You might be definitely better than me. See, the polycythemia, the only thing which I want you to remember with respect to polycythemia is few keywords. I'll just add on to it. It's also a chronic myeloproliferative disorder. So you know the origin. Origin is going to be the bone marrow stem cells, right? Polycythemia rubra vera. It's same hematopoietic stem cell. The mutation of polycythemia vera, there are two things, but remember one, that's more than enough. JAK2 gene is going to be mutated. I can have JAK2 V617F or JAK2 exon 12 deletion. Okay. So there are two things which will cause polycythemia vera. Fine. Coming to it, just give me one. Fine. So polycythemia vera, the clinical feature, again, elderly person, flushed face, and the most important thing, there's a condition called aquagenic pruritus. The patient will have itching, intense itching, post taking bath with a very cold shower or taking bath a very, very hot shower, right? You'll have intense itching, that's aquagenic pruritus. That's very, very classical of polycythemia vera. If there's a reasoning why question asked, why do you have aquagenic pruritus? We actually don't have clear-cut answer. I'll tell you the proposed thing what is there for aquagenic pruritus. They say that the extremes of temperature, hot or cold, will release lots of histamine from the mast cells that creates the itching. That's what is being supposed the reason. But if they ask you, just give you that's the reason available as of now, right? So how do I diagnose polycythemia vera? It's purely a criteria-based diagnosis. Okay. So for polycythemia vera, we have major criteria and we have minor criteria. We'll look at the minor criteria first because it's very easy for us to know, right? See, polycythemia vera is a cancer of your RBC lineage, right? Erythroid lineage, right? So it's a cancer of erythroid lineage. What should be the growth factor level? Should be less or more? It should definitely be less. So here you should have, most importantly, subnormal erythropoietin levels. If your hemoglobin is 18 milligram percentage, and your erythropoietin is also high, it is not polycythemia, it is reactive condition. Maybe you are having asthma, lungs are struggling to take care of the oxygen, so increases RBC. Or you're an athlete, it can cause. High altitude, it can cause. You should have subnormal erythropoietin for me to diagnose it as polycythemia vera. That's the first and the most important thing, right? Then in bone major criteria, I'll go with the easiest one. Then we'll go with the difficult one, which is the numbers. Already we know mutation, right? Presence of JAK2 mutation. Okay, that's there. B617F or JAK2 exon deletion, right? Next, bone marrow biopsy. Bone marrow biopsy, all the myeloproliferative disorder is nothing but proliferation of everything, and that is very, very classical for polycythemia. You should have a finding called panmyelosis. Pancytopenia is loss of everything. Myelo is bone marrow. Panmyelosis is RBC, WBC, megakaryocyte. All of them proliferate in case of an polycythemia vera. And the most important is the first major criteria, which is the hemoglobin level. Right? Hemoglobin more than 16.5 gram in men and more than 16 gram in women is considered to be polycythemic. It's as per the latest WHO criteria. Robbins might differ. So this is as per the latest one. Go for it. Or I can use hematocrit. Though most of the places they don't use hematocrit. More than 49% or more than 48% in women. With respect to hematocrit, I can call it, right? So based on the criteria, you'll be able to diagnose polycythemia vera. And just a word about treatment. We have bloodletting. You cut and lose the brain. See, polycythemia is a very chronic disease. It can be there for years together, right? Cut the venipuncture, let out the blood. That's one way of treatment. And I have JAK2 inhibitors that also can work, which is ruxolitinib. I hope I'm right with regards to it. That's a targeted therapy for polycythemia rubra vera. Fine. Okay, perfect. See, Bhagwat, like I said in the start, I forgot to put the clinical cases here. I had given you few keywords in the start, so I'll just put the keywords again randomly. I want you guys to tell me what do you think will be the diagnosis, right? Just random keywords. Let's see if you can pick it up. Fine. Case 1. An elderly person, or let's not write. I will talk about it. You tell me the right answer. Let's see how fast you're able to catch it, right? Because once I write, it becomes much easier, right? Let's make the training difficult so that the exam becomes easy. Okay. A 45-year-old person presenting to the OPD with symptoms of multiple swellings in the neck. On examination, it was found to be lymph node enlargements, generalized lymph node enlargements. Peripheral CBC was done. The WBC count was 48,000 with an absolute lymphocyte count of 25,000. What's your most probable diagnosis? I just randomly told so that you will catch the keywords while I talk and you'll be able to answer it. That's most likely diagnosis of CLL, right? Lymphocytosis, leukocytosis, elderly generalized lymphadenopathy, CLL, right? Second, a 20-year-old person came to the OPD with a history of lymph node enlargement in the cervical region. Okay. Peripheral smear was done. Peripheral smear is normal. Lymph node biopsy was done. Lymph node biopsy shows multinucleated cells along with nodular proliferation of lymphoid cells in the background, and these multinucleated cells were positive for CD20, CD45 and negative for CD15 diagnosis. I'm just making up, so tell me what's the answer. What do you think of the answer? Second is NLPHL, right? A young age person, cervical lymphadenopathy. I didn't tell popcorn cell. I just told multinuclear giant cell because the moment I say popcorn, everyone is going to spam saying NLPHL, right? But multinuclear cell, background B cells, nodules, positive for 2045 is diagnostic of NLPHL. Fine. Okay. The third one. 5-year-old kid came to the OPD with history of bleeding gums and also just Epistaxis on and off. Peripheral smear was done. WBC count is like 15,000 and peripheral smear showed blast. What's the diagnosis? Model, I won't think of Burkitt's in that case. The older thing was NLPHL. Burkitt's classical star is K, no? This is very, very simple. I'm sure you know the answer, which is ALL. Child blast is definitely ALL, right? It's not difficult at all. Okay. 4. A 45-year-old person came to the OPD with a history of vague left hypochondrial pain. On examination, CBC shows leukocytosis. Diagnosis. I am avoiding few things so that you can pick the right answer. That is CML, right? I didn't tell massive splenomegaly. I told left hypochondrial pain, right? Science Philiac, amazing name. Fan of your name. Classical case of CML, right? Okay. A young child with swelling in the jaw. Microscopy shows, I don't think you require it. Diagnosis, Burkitt's lymphoma. Okay. Next. A 45-year-old person came with history of altered bowel habits. On examination, colonoscopy was done, shows multiple polyp in the intestine. Biopsy of one of the polyp showed diffuse effacement of the epithelium by B lymphocytes, small B lymphocytes. What's your diagnosis? What do you think is the diagnosis? It is mantle, classical lymphomatoid polyposis, right? Perfect. Great, guys. Great. Great doing. You're done well. Keep reading. My next FARRE will be after a hiatus of 1 week. I think pharmacology and microbiology will be in between. In the WhatsApp group, I'll tell you whenever the day before the FARRE what to read. Be prepared. We'll do the same thing for almost every important chapter and make sure we'll clear the exam in flying colors, right? Thank you for your time. Bye bye.